Next point is the potential for chronic, long-term neurological and psychological sequelae. And with that comes medical, legal, and insurance risks. And then very importantly, I believe that if we're going to be a doctor in the sport and exercise environment, to be credible in the message we deliver, we have to acknowledge that we understand a lot more about concussions than we did, that there's a spectrum of concussions, and that there's a differential diagnosis. Because if we're treating everyone the same, then we're not acknowledging that this is part of a spectrum of injury. So I like to always remind myself why we take this seriously. When I was last with you, I showed you these slides, which in a way illustrate how concussion occurs and what is happening at a neurological level. And it simplifies it significantly, but it helps explain things. And I would like to acknowledge my colleague in Boston, Dr. Bob Cantu, who put these slides together. But when we look at normal neurological function in the brain, the function of the neuron, a signal arrives at the neuron, it travels down an axon to another cell, and through a very organized set of neurotransmitters, chemicals that transmit that signal across the synapse, it triggers the next cell with a very specific coded message. Things are different when there's a head injury. What happens is during the injury, potassium ions rush out of the cell, calcium ions rush into the cell, and that leads to metabolic dysfunction. That message is not able to be transmitted along the axon in a very regular manner. In addition, there's a massive release in a very disorganized fashion of the neurotransmitters that interferes with cell communications. And this leaves a very inefficient cell that doesn't transmit signals and results in what we call an energy crisis, where the cell is not getting the energy that it requires, and in this state becomes very vulnerable to further injury. It may take days for the nerve to return to normal condition, but after several days, usually that ion influx and efflux reverses, and after many days or even weeks, the function returns to normal. Another analogy I like to use is of a 5-lane highway that's carrying busy traffic at rush hour. And if you look at that highway, one lane is carrying perhaps cognitive traffic, another is carrying emotional traffic, another balanced traffic, another is carrying different types of traffic that determines brain function. So each of those lanes has a specific function. And what happens is in the concussed athlete is that there's an accident that occurs. And that accident blocks off one or more of those lanes. And depending which lane it is will determine which area, which domain is most affected. So it may be cognitive, in other words, thinking, it might be emotional, it might be balance, it might be sleep. There are all sorts of areas that could be affected. And so it presents differently in each individual. And if you try and overload that brain with normal activity, either exercise or cognitive or other forms of stress, all you do is you're trying to push normal rush hour traffic down the remaining 2 or 3 lanes, and that leads to a backup, which is often the sensation of what concussed athletes feel. And our job as clinicians is really to open up the highway and allow the traffic to flow again, and that can take some time. So that is a nice, or 2 nice simplistic ways of looking at concussion, and hopefully it clarifies in our mind what might be happening, and I still like to hang on to those. But unfortunately, it's not that simple. And as we learn more about concussion, the neuroscientists are telling us that it's a much more complex injury than we thought before. So this group, and I've sent Dr. Holshausen the papers that this group released in 2017 and 2018, a group of neuroscientists from Portland in Oregon, described what they called a mapping of pathophysiology, persistence, and recovery with a technique called causal loop diagramming. So if we go back to our little neuron transmission, we go back to our traffic theory, you'll see they're very simplistic when compared with the actual picture, which looks something like this. And I think, you know, if we went through this in detail, we'd certainly need more than an hour. But I think it very eloquently presents to us what may be going on in the concussed brain. So this causal loop diagramming of concussion pathophysiology is a model that shows the causal relationships between factors that influence both the causes of concussion and the recovery from concussion. And these feedback loops occur in various areas, and they can both exacerbate concussion and can cause recovery from concussion back to a state of homeostasis. So if we have a look across the top scale, you can see all the various domains which influence concussion, the actual impact, what's happening at a cellular level, what's happening in the networks between the various neurons, and how that is influenced by that patient's experiential and social interpretation and context of that concussion. And if we look at this, we can break it down into the various areas and then various networks. But what I would encourage you to do is two things. One is to get the papers and read them. And the second is to go to this website here, dynamicsofconcussion.com, where it's actually both explained and illustrated on that website, which is very, very useful. So it helps break it down into various different networks or loops. And so you can see, for instance, in the top left, how sleep may help repair the concussion symptoms. How physical exercise can also be restorative, but can, in some ways, if overdone, cause an excessive stress, and how emotional stress and social functioning can also affect these various loops at a very chemical level. And that's the point, is that the impact of various influences on concussion affects cellular energy and affects the imbalances or balances of the chemicals across those neurons, as we saw in that very simplistic version. And whether it exacerbates it or it helps alleviate it will determine the recovery. And as clinicians, we need to determine what are the major domains involved and what are the interventions in terms of trying to alleviate the symptoms and allow that nerve to return to homeostasis. And so you can break each one down into very specific influences, which, as I say, work right down to the level of mitochondrial function and oxidative stress, proteolysis, etc. So it's a very complex system. I would like you, if you're interested in concussion, to go and read more up on this hypothesis, but to take away the message that it is a very complex area that involves very many different levels. And these levels were explained in their second paper, which looked at this multi-scale complex and divided it into that cellular, network, experiential, and social levels. And these are the factors that influence concussion pathophysiology and recovery. And they're divided into endogenous factors, which are situated in those boxes and included inside those boxes, and exogenous system drivers that act on the perimeter of those. So it's very important to understand that there are endogenous or inherent aspects in a patient's physiology, in their genetics, which may predispose them. And this may include previous experiences of concussion, as well as external influences, which will determine how we manage that patient. And although it seems an extremely complex process, as I've mentioned, all one needs to understand is that you need to acknowledge the different influences, and particularly in those more difficult cases of concussion, look at strategies of bringing in expertise to address this. And I'm going to talk to that a bit later. So I wanted to start off with that introduction, showing you potentially how complex concussion is, to show you why it's very necessary to work through a systematic process when we're trying to bring together experts to systematically review what the science has taught us about concussion or any particular area. So this process started about 18 months ago, where organizing and scientific committees were put together, lead authors and co-authors were identified, and they were identified according to their contribution to the science and the literature. We have a methodologist that's allocated to each of the 12 groups to allow us to systematically search the literature better and proceed in a bias-free manner through the process of writing the paper. We have identified keywords, seed articles, and databases, and through our collaboration with the University of Calgary as a Concussion in Sports group, we have conducted the searches which are now complete, drawn up protocols for each of the papers, submitted those to the prospective systematic review database online, Prospero, and the search results, all the papers have been exported to a tool called Covidence, which allows all the co-authors to access them. Where we are at the moment in the various papers is we're going through those full text reviews, which have been allocated to experts in the field on each paper, and we're extracting the data according to a standard table, and then putting that through a risk of bias assessment, after which we will draft the papers and write them. So just an idea of the process that we're going through. That brings you to some sort of conclusion that we reached in Berlin in 2016, where, as you're aware, the 11 R's were identified of concussion and written up in that special edition of the British Journal of Sports Medicine. And so when we look at 2020 or 2021 as it is now, we are working on a similar type of template, but just trying to tweak it and upgrade it a little bit. So we're going to re-look at the definition. We're going to look at the recognize and remove aspect, the removal aspect, important, the tools we use to do that. Very importantly, the re-evaluation aspect is going to focus on the office assessment, which needs, we feel, a more specific tool. We look at not only rest, but we now know that the exercise component plays a significant role, and we need to look at how we can introduce exercise into that process. Rehabilitation in a multi-system fashion. We've shown on that pathophysiological discussion that we had that there are multi-systems involved. What skills and investigations are needed in your referral network? How do we define and facilitate recovery? Return not only to sport, but school, work, driving, etc. Look at the residual effects and sequelae, that controversial area of concussion in terms of chronic traumatic encephalopathy and the long-term psychological effects potentially. A new area that's been brought in is that of retirement. When do you tell an athlete to retire? What are the criteria we use? And then risk reduction and, importantly, pediatric components, which will be cross-cutting across all of those different papers. Each of those will look at a pediatric component. So that's an outline of the next consensus paper. So if we're looking at a complex system such as this, as I've mentioned, we need to do it very systematically. So I'm going to go through each of those aspects carefully, and I've put the heading at the top with the lead author's name underneath that. And the first of those is, of course, concussion's definition. And if I asked all of you in the auditorium or behind your computers what the definition of concussion is, I'm sure I would get a whole lot of different definitions. And as you know, the consensus meetings of the past have pulled together a concussion definition that is several lines or paragraph long. But the key aspect is that it's a disruption of brain function, and that's very important and will remain unchanged until we can get imaging techniques which show us what's actually structurally happening in the concussed brain. And that is some time away and certainly not going to be accessible to most people. So as long as you accept that it's a trauma-related event occurring to the brain that results in a disruption of brain function, you have a good idea of the definition of concussion, and we will be working around that. You know that after recognizing concussion, the next thing is to remove the player. But to recognize concussion, we need specific tools and guidelines as to what to do specifically. And so Ruben Ekimendia's group will be looking at those sideline injury detection protocols, looking at the concussion recognition tool, the CRT, which, as you know, is for the lay person, and then looking at upgrading the SCAT5 and child SCAT5 to the SCAT6 and child SCAT6. And then very importantly, looking at the role of technology, impact detectors, etc., which you can put into mouth guards, helmets, behind the ear of athletes to try and detect impact and whether that's significant enough to take a player off. Similarly with accelerometers. So technology will certainly be looked at and the SCAT5 will be updated, but you should be, as clinicians, quite familiar with the SCAT5, and it will probably have a similar appearance, and we hope we'll be looking at an app form of that as well. My role in the group is to look at developing something that takes that initial evaluation further in terms of an office assessment, the sports concussion office assessment tool, and a child version of that. Those of you that evaluate concussions in the office will know that the SCAT tool is inadequate to do that things have often evolved and you need a more complex tool to determine which of those domains that we discussed are most significantly affected. And a lot of attention has been given to the vestibular and ocular function that's disrupted often in a concussed athlete and how we should be evaluating that. So we're looking at developing a tool which at the moment is 20 pages long, which is very bulky. And that tool will be able to be used for those really severe cases and difficult cases which are complex and need to be evaluated repeatedly, perhaps with potential sequelae like retirement, but also needs to be in a form that's practical and can be easily used by clinicians who are less familiar with concussion management. And so that's the strategy for us. And we'll be putting a lot of emphasis on neurological evaluation, ocular evaluation, and vestibular assessments of the athlete. We need to take this further. And if we look at the coming slides, you will see that there are areas of concussion management which require other attention. And so if you look at the disabled athlete, for instance, these competitive para-athletes, and you look at how hard they fall, you will acknowledge that we need protocols to see how we can best manage these athletes as well. These are significant impacts. And so what we've done is we've put together a special subgroup who have expertise in the para-athlete to look at ways of customizing the evaluation of these athletes. Many of them have very different disabilities. But if you look at these wheelchair athletes, how do we assess their balance, for instance? How do you, if you look at other athletes such as these here, who are visually impaired and undergo concussion, you'll see a significant impact occurring there. How do we evaluate them from an ocular and a vestibular point of view? And so we need very specific protocols which now acknowledge that perhaps we haven't looked at all the spectrum of athletes that require our attention. And that's the role of this group. And then female athletes might be another one where we know that they're probably more predisposed to concussion, and what protocols we have in place that specifically look at evaluating them and preventing their concussions as well. And again, I come back to this very complex scenario that we've looked at and try and bring it down to this. So we're going to be looking at bringing it down to domains, and I think that when you go from there to there, it becomes far more workable. We're going to be looking at the major domains which have been identified: neurological, cognitive, mood, behavior, autonomic, sleep and hormonal, cervical and vestibular. Look at ways of assessing each of those and then look at interventions for each of those as well. And that's really the template that we're going to be looking at and developing a tool that hopefully you and your officers can use and apply to athletes to their benefit. The next aspect is that of rehabilitation, which Catherine Schneider is heading, and it's probably the area that we've made the most progress in concussion in the last 5 or 6 years. We now recognize that concussion is a treatable injury, and we can actually give exercises and interventions to athletes, similarly to rehabilitating a hamstring, for instance, that will allow those networks in the brain to reestablish themselves in a very specific way that address things like headache, cervical pain, vestibular dysfunction, visual issues, autonomic dysfunction, hormonal, mood and behavior, etc. And as part of that, you will have come across this protocol called the VOMS, or Vestibular Ocular Motor Test, and it is a very nice 5 to 10 minute evaluation that looks at 5 different aspects: smooth pursuits, saccades, convergence, the vestibular ocular reflex, and the visual motor sensitivity test. This is a particular version that was described by the University of Pittsburgh Medical Center, Michael Collins in particular, and it's a nice 5-minute screening tool that gives you good insight into what might be happening in the ocular and vestibular systems, bearing in mind that the tool described in the SCAT-5 really just looks at balance, which is quite blunt. So we now have the ability to extend that, and I encourage you to go onto YouTube to look at some of the videos available and determine how you do horizontal and vertical pursuits, horizontal and vertical saccades, near point convergence, horizontal and vertical vestibular ocular reflex, and the visual motor sensitivity. They're very simple tests that require a metronome, which you can get on your phone, a tape measure, and a stick, and they can be done very easily. The vestibular ocular reflex is done with a metronome set at 180 beats per minute, and the visual motor sensitivity body movements at 50 beats per minute. So very useful tools which have taken us forward since the last described evaluations and will be incorporated into not only rehabilitation techniques, but the office tool as well. Being a team doctor in a sport such as football can be quite lonely. And when you're left with an injured patient and you're left with coaches, team management, and team owners who are encouraging you to get that player back as quickly as possible, particularly when there's no visible wound, but you know that player is injured, you need support. And when you're dealing with a complex network of potential causes such as this, you need to develop that network around you. So one of the things I try and encourage clinicians to do is to establish a network and a good communication system that surrounds the athlete. And you need to do this before the season starts. No good rushing around once an athlete is injured. You need to have this network in place. And I'm sure you'll appreciate that if you have expertise such as this available, then you feel a lot more comfortable in terms of managing those specific cases. So if you take one particular presentation like the vestibular ocular system, you could actually undergo a 3-hour evaluation in terms of the type of detail that you need to go into. And as clinicians, sports clinicians, we don't really have the skills to do that, and you need people to support you. Similarly with ophthalmological investigations, neuropsychological investigations, physical therapy, etc. And then to bring people around the athlete into play as well in terms of the team, the family, and the academic team if they're studying, and make sure that all of these people understand what you're trying to do before the season starts. And this is particularly useful when symptoms become specific into one particular domain or persistent, where detection and management is difficult, where you need specific skills, and where there's a differential diagnosis involved. So perhaps the injury might cause a manifestation of anxiety and depression, for instance, which wasn't detected before. But that referral network becomes increasingly important. In terms of recovery of the athlete, very importantly, we're trying to evaluate the science around what stimulates recovery in the athlete and what interventions will aid that recovery. So in terms of detecting severity of injury, there are some very interesting forms of technology which have come to the fore. For instance, salivary markers as diagnostic and severity markers of concussion, where you take a salivary test, you look at things like microRNAs or other proteins, which might show up in proportion to the severity of the injury. And we may be able to monitor that recovery to allow us to more scientifically guide a player back. Also, what interventions, you will have seen descriptions of various supplements around. What science is there behind that? And can we actually advocate the use of various supplements in concussion? There's a lot of claims out there, but perhaps not many of them backed by science in both defining the recovery and aiding the recovery. Returning to sport is obviously the key area that we want in terms of getting our players back. What is the timing? What assessments will determine that? And what is the soonest they can get back? And you'll know that there's a stepwise approach that's been determined. And I think it's also important to customize that approach for your particular sport, and also to determine not only return to sport, but return to learning, return to work, return to driving. Very important to try and look at the person, the athlete as a whole. A lot has been said about the residual effects of concussion, the effects on the brain from a neuropathological point of view, the effects on the brain from a psychological point of view. And there's a subgroup set up to look at the long-term effects in a scientific manner to determine what the permanent or late onset of symptoms or deficits are, whether the age of participation in a contact sport, the first age, makes a difference, what the risk factors are, whether there's a specific number of concussions which have an effect, how to monitor the heads to injury, and then look at implementing longitudinal studies in different sports, including soccer, that will determine, give us the information we need to make these decisions. And then finally, we said retirement. How do we make decisions around retirement? And you will have seen, again, related to the residual effect type of research and publications, research around what the effects are. And there seems to be a trend showing that there is increased neurodegenerative disease mortality in contact and collision sports, but actually a lower incidence of psychological conditions. And in fact, it seems that people that play particularly team sports seem to be psychologically healthier, even if they played it at a very high level, than those who've never played those sports. So what are the criteria for retirement? How many concussions should we consider? When should they be retiring? And what's the process that should be put in place? Those of you that deal with athletes towards the end of their careers, or those who have had significant number of concussions, will realize and appreciate that this tool will become very, very useful to you. Finally, in terms of reducing risk for concussion, we've learned a little bit about strengthening the neck. There's some good work that's been done around that. We've also learned that the eye plays a significant role. And I think that one of the areas we've ignored is how we can actually prevent concussions by improving ocular skills, reaction times, and the interaction between the vestibular and ocular systems, and that we should be incorporating this both in terms of our training and in terms of our rehabilitation of concussions. So there will be a paper on risk reduction which teaches us a lot about these things and the science behind them. So in concluding, we're looking forward to what would have been Paris 2020 in a month's time, now going to be in a year's time. And we hope that we will evolve sufficiently to have learned a lot. Now, my friend, Dr. Holzhausen, who's presenting these seminars with me, has really walked a similar path to me in terms of our roles as team clinicians. And we've been working in a sport called rugby since the 1990s. And if we think back to what we knew about concussion when I started in 1995, we were only diagnosing concussion if you lost consciousness or had amnesia. Those were the only two criteria, and we used to grade them as 1 to 3. We didn't have tools to help us recognize concussion. We didn't have any skills to intervene in concussion. We didn't base our interventions on any science, and we had no way of enforcing this. And over the years in rugby and in other sports, we've seen significant numbers of concussions which have occurred. And the science that has gone into this over the last 20 years has been significant and has allowed players like this to get back to playing at the highest level of the game, and hopefully without long-term sequelae, as the science helps us manage the player's recovery and guides them back. So if we look at where we are in 2020, we have a much broader definition of concussion. We have an awareness about concussion that's been spread by the media and social media. Some would say to an extreme. We have research, exponential number of papers that have occurred over the last decade, a number of publications and that have given rise to 5 consensus meetings, and we have specific interventions which we know will help the injured player. What's very important is that we continue to be innovative. This is a paper that was published a week ago by a young researcher, PhD researcher, who looked at a self-report outcome measure of functional status. Remember, it's a functional injury. So how do you measure or get the athlete to measure her or his functional status? And they looked at this particular tool, which, as you can see, looks at a number of those domains that we've mentioned. So these sort of innovations are important. And in today's talk, I'd also like to acknowledge this innovation, which I think leads to a significant step forward in the way we manage concussion in specific contexts. And what your group has done here, I think, is significant and should be replicated across the world in taking concussion consensus and translating it into contexts that are relevant for particular cultures. And I think that's very important, and congratulations to you. So Paris, we're really going to be building on previous consensus meetings and the templates that have evolved from them, especially those 11 themes from Berlin. We're going to be answering specific questions directly, including what are the technologies that are most specific? What are the tools that are most useful to the clinician? What are the tests that we all need to be doing? What are the criteria for determining when a player should be retiring, etc.? And we're going to be providing practical tools and the guidelines that can be used in multiple scenarios by people such as you. But very important, it's important that you take those tools and you translate them and you apply them in your environment. Otherwise, they are meaningless just sitting in a journal or on a website.